Okay. Hi everyone, my name's Ed. I work at MedStar. I am a recovering physician. My previous life, I was internal medicine, and I worked for, I used to run the pre and post cardiac surgery care for MedStar Union Memorial Hospital. So I did that for 9 years until my recent foray into innovation. So my kids, actually every few days, they draw on I have a dry erase wall at home, and every few days they write, they mention my cool work. So there was a time where I worked a lot clinically, and then a time where I worked with MI2 and then MedStar Institute for Innovation. I'm going to keep calling it MI2. And I finally made the switch to full-time MI2, but they still refer to it as my cool work. So I'll get to why it's so cool, and hopefully how it can benefit you all. So first, a little bit about MedStar Health. It's actually the largest health system in the area. It has 30,000 associates, 10 hospitals, 6,000 admitting physicians, and it spans the geography between Baltimore, DC, and Southern Maryland. And also, not only is it geographically disparate, but it also has different types of care providing settings. So be it a university setting, community hospital, even tie your horse to a pole rural hospitals. Basically the whole span of healthcare. And as far as some of the regional impact, actually that's the MedStar Helicopter flying over the Pentagon on 9/11. This is a picture down here of ER1, which is sort of the emergency room of the future for the DC area. And you can see a map of some of our touch points in the area. And then just a little bit about the typical day at MedStar. About 636 new patients a day, 1,800 patient admissions. You can see 50 babies delivered a day, 760 home care visits a day. So pretty big regional impact. Now, just being a health system by itself has certain challenges, internal and external. External, some of them are obvious. The financial challenges, the regulatory challenges, these sort of things. And then internal, I was mentioning the geography and having, sometimes one hospital has a certain culture or flavor, and then another has a different one. And how do you operate as a real system? So in addressing some of these challenges, in 2009, Ken Samet, who is the CEO of MedStar Health, chartered the MedStar Institute for Innovation, which we abbreviate MI2. Up there is our official logo. That's the one we have to use by marketing's stamp of approval. But this is the cool emblem that we use on hats, modes, and little icons and avatars. So, but in 2009, Ken chartered the MedStar Institute for Innovation, and he appointed Dr. Mark Smith as its director. He has a history of being in emergency medicine, but also has a background in computer science and mathematics. So he created an electronic record called ization, which was later purchased by Microsoft and became Amalga, and now is part of a Microsoft GE joint venture called Paradigm. So anyway, he was appointed the director in 2009, and when he was asked, so what do you want this Institute for Innovation to be? And Ken Samet said, if I knew what it was going to be, it wouldn't be innovative. So get some people, get together, and figure this thing out. So Mark Smith built it on a couple foundational principles. One is that there's a vast amount of untapped intellectual capital, basically everywhere, but specifically at MedStar Health. You are not your job description, basically. So we have passions, we have interests, we have talents, we have skills, and many of them are not necessarily being utilized if people are boxed into their day jobs. And then the tyranny of the daily trumps the pursuit of the remarkable. So we're in our day-to-day, and Jason and I were just discussing this earlier, how you can be in the day-to-day, in the weeds, that you may not be thinking about what's over the horizon, what's coming over the next mountain. And so that's what MI2 set out to do. Now, just to be clear, since I have innovation in quotes, when we say the word innovation, sometimes it means different things to different people. It's sort of like, I hope it doesn't reach this stage, but it's sort of like quality, sort of like, these sort of words. But innovation, for some, it means process improvement, okay? stepwise improvement. For others, it is limited to tech transfer, okay, taking an idea and commercializing it. But in MI2, we actually like to think of it as any jump shift. So how do you go from a candle to a light bulb? How do you go from a horse to a car? These sort of jump shifts, not micro improvements along the way. So another thing about the cool work, did you go to your cool work today, are the people and the domains that we work in. So there is not, one of the beauties of working where I work. I live in Catonsville, I commute to DC 3 days a week, and the rest of the time I'm in Baltimore. It is so worth the commute because of the people I work with. Not an arrogant ounce in their body, and all of them brilliant, and all of us have imposter syndrome. We all think, like I feel right now, I can't believe I'm speaking to you. In other words, like, am I worthy to be here? All of us sort of feel that way all the time. And so I'll tell you a little bit about some of the domains that we work in. I'm going to move over here so you can see it. The first is MedStar Inventor Services. This is where we allow basically all of the MedStar associates can submit an idea as maybe it's on the back of a napkin, or maybe it's all the way to prototype. But they can submit an idea, and then MedStar will help through the commercialization process, vetting it, intellectual property, market potential, all of that, helping to prototype, fund it, and then if and when it goes live and is commercialized, then split it 50-50 with the inventor. That's MedStar Inventor Services. I'll mention it a little bit later. The National Center for Human Factors in Healthcare. This is actually, for those of you that don't know what human factors is, I'm going to touch on it. But this, to me, is the most awesome part of MI2. And the people that all work there blow my mind every time I talk to them. Like, if I'm just getting a coffee, I leave with my mind blown. It's just an amazing field. So human factors, I'll touch on what it is, but in the next few slides. But human factors is, we have the largest human factors in healthcare center in the nation. We have several PhDs. Some have PhDs in human factors engineering, and some on the psych side of it. And I'll mention more about that. We also have a usability division there, which may interest many of you for testing devices or apps or web pages or what have you for usability. We have a simulation and training environment where a couple wings to that. One is to train actual healthcare providers. Maybe it's a surgical procedure, maybe it's CPR, or what have you. Maybe it is interpersonal relationships. And then also we have a serious games side to that. So where we create simulated environments, 3D worlds, where, say, a surgeon can act as the anesthesiologist or as the nurse in a surgical situation. And then there's some AI in there that accounts for all that. Infonovation is a term that I would like to abandon, but it's basically deals with higher level software kind of things. EHR development. We're working on a personal health record where the patient owns the data. Telehealth initiatives and mHealth. So we have sort of a domain there. Care delivery. So we have something called Elder Care, which works on getting care into the home in more innovative ways. Complex systems. For those of you that aren't familiar with complex systems theory, well, actually, it's probably not worth going in depth here. It's probably not relevant to this. It's complex. But basically, things that are complex, like a flock of birds, might operate on 2 or 3 simple rules. So if you can identify those simple rules, you can completely change it's essentially the rudder. If you have a huge ship and you're trying to steer it, it's the rudder if you can understand the simple rules in a complex system. So we actually think healthcare should be viewed as a complex adaptive system. And so we're working with the Santa Fe Institute on how to address that practically. And then presence, which is what I do. So if those of you who have my business card might look at it and say, WTF, what's a director of presence? I'll get into that as I go.
Attendance.
Yeah, exactly. I'm going to touch on just a few images. The MedStar Inventor Services is done through a partnership with the Cleveland Clinic. So they have a very well-oiled machine on commercialization, everything from the market research to the prototyping that they do on their own. So we actually have we were the first of several Cleveland Clinic Alliance partners where they have Cleveland Clinic staff on the ground at MedStar that help when people bring their napkin idea in to get it commercialized. So that is really a promising thing. We have, I think, almost maybe 200 disclosures brought in so far, and they're not all like physicians with bringing a knee or a new stent or something. Some of them are from finance, some of them from social work. It's just it's really quite remarkable. To touch on human factors, if you look at this door, is it push? Is it pull? Right? It says push, but that handle indicates pull. That's essentially what human factors is. If you've ever pushed on a pull door, it wasn't your fault. It's not Midvale School for the Gifted, that old cartoon, right? It's a human factors issue. It's a design issue. It was not designed for human use, or for ease of use by human. It actually encourages error, and so anyway, that's one example. Here's another, and this is actually, I took this photo. I was at a hospital. I was in the parking garage, and I pushed that button to push the elevator. So the one with the flames is not the right button. That is the elevator button. The one without the flames is the emergency button. The one closest to the elevator is the emergency button. So guess what? I pushed that button, and I said, and security came over. Is everything okay, sir? And I said, yeah, everything's fine. I'm sorry, I was trying to push the elevator. He's like, dude, happens all the time. I was like, yeah, I bet it does. So that's a design issue. So that's human factors. Here's another thing. Try to identify the abnormal labs. Doesn't matter if you're a physician or not. Here's the normal range. Here's the actual lab value. Try to identify the abnormal labs. And raise your hand when you identify it. Okay, we're starting to get a few. All right, now I'm going to do the same exercise. Do it now. Raise your hand. Okay, see, that's human factors. And this is actually not a very good user interface, but it's a lot better than what we have in most of our electronic records. So that's human factors, essentially. Yeah. This is our simulation and training environment. There's an example of serious games where you have a patient and then simulation there. Now, my kids drew this one. Can we go to your cool work tomorrow, please? And then they're all standing at the bottom of these steps. I have 142 steps to climb from my parking to the office. But this also is, I put this here because I'm about to get into some of the stuff that I do. And my journey might sound bizarre because I'm a physician. Why am I working in mobile, in games, in influence, and social? How did I do that? Well, over time, I sort of had a slow hunch. Early on, I felt like I was burning out and healthcare was sort of heading in the wrong direction, so I started looking for alternative career paths. And I sort of fell in love with entrepreneurship. I started my own little online businesses, membership sites, those sort of things, and ultimately ended up with I have a little iPhone game company. But along the way, I started learning marketing, and then I started, and I fell in love with that as well. Started applying marketing at the bedside for influence principles, and then started learning other realms of influence. And what I would do, my strategy was to go find an expert in whichever domain I wanted to learn, and then go learn from them. So for example, I might say, who are the masters of teamwork? Well, maybe it's improv groups. Maybe it's jazz musicians. What can we learn from teamwork from those folks? Who are the masters of rapport? Pickup artists, con men. Like they get people to do things that, how do they do that? What are their strategies? And can we use them with good ethics and in a good way? So basically just who are the masters, and then can I go learn from them? So I did that for marketing, I did it for game design, and that's sort of how I ended up in this weird thing that is Ed Tori, the director of Presence. So the idea behind Presence is that I want to be where people are. And so where people already are is on their mobile devices, in their interpersonal interactions, and social. Okay, their social networks, be they virtual or real. So in influence, I teach courses on influence. We have a course coming out for influence for healthcare professionals. And actually it borrows from things like hypnotists, conversational hypnotists, even pickup artists, marketers, sales, clergy, coaches, parents, anyone who's an influencer. Personally, I think healthcare should view itself as an influencer. Under mobile, we have through our inventor services, sometimes people submit ideas for apps. So we are creating a wayfinding app that also translates signs in the hospitals. We have a therapy app for people who are recovering from facial palsy. So this is about to come out. Recently, I was at the Health Data Palooza. I was part of a 4-member team for, they had a Codapalooza, or a hackathon, codathon type thing, where you took Medicare data and had to, billing data, and had to use it clinically in the primary care setting. And so we actually ended up being the winning team, and we created something we called the Betterfly effect, which is sort of a little widget that displays the data differently. But instead of it being a new system that you have to log into, it lives in all those other systems. So we made a working prototype. It might live in a scheduling it might live in a scheduling program. It might live in the EHR, or what have you. But basically, this is a way, just to give you an idea. This is time, and above this is all borrowing Medicare data, which basically would any contact they had, a patient had. So this is any one above the bar is inpatient, any below the bar is outpatient. Blue is in your network, red is out of your network. The height of the bar reflects cost. So at a glance, you could see, as a physician, I can tell you, most of the time, I have no idea what happened before you got there. I am clueless. If it didn't happen and it's not available in our electronic record, I have no idea. And so this, all of a sudden, I could see at a glance maybe a little bit about complexity. So that was from Codapalooza. Now, you may also have heard of gamification, where you take game elements and you take a mundane task and add game elements to make it more engaging. Well, we sort of flip that on its head and we say, instead of gamifying health, we wanted to healthify games. Games are very popular, the biggest apps downloaded by far in the App Store, certainly also the most lucrative. And we thought we could use influence principles embedded in the games to reach the general population, not patients. We're not saying, here's a game for your diabetes. We're saying, here's a game, and you may actually learn something about diabetes in a subtle way embedded in the game. So I'll just show you a couple examples. This was our first one. It was just sort of a test game to get it out there. It was hospital invaders, and you're learning about infection. And there's ways to learn about the actual bugs that you're shooting with antibiotics. But I don't care if they actually read the text. I care that they feel good when they hit the soap. I care that they feel good when they hit the gloves. I care that they feel bad when they cause resistance. And so anyway, that's one example. This one was just released, and probably the low point of my career. It's called Traveler's Diarrhea. But basically, it's a running game, and if you pick up the wrong types of food, the types that are more likely, like ice cubes, lettuce, the sort of things that will trip you up on a trip, give you the runs, so you're running in this game. A couple more coming out soon, one called Allergen, one called Fitzo. And then there's also some gamified quiz games for medical education. So Patho Quiz, Finding Pneumo, which is a chest x-ray. Pneumo is an air outside the lung.
You write your own script.
And then this is a sort of a tower defense game learning about mosquito-borne illnesses. So that's the healthification of games. And then social collaboration, we have am I doing okay for time? Okay. All right, so social collaboration, we have teamed up with SocialCast, which is it's a social platform, and that sort of works like Facebook, LinkedIn, Twitter, but within our health system. And we call it My 2 Cents, MI2, My 2 Cents. And I personally happen to think that it could mean the death of email, at least not necessarily the death, but certainly I don't know. If you think about email, you have to know the person you want to interrupt to actually, and then reach out to them. But social works the other way. You post something, and then people say, "Hey, that's pretty cool. I'm interested in that," or "I know something about that." And so that's one of the ways of finding the untapped intellectual capital at our health system. And also having people weigh in and help out with ideas and feel good about the work they're doing because they're contributing where they want to contribute, not where they have to. So anyway, email. And also, one of the things is that MedStar Health is a typical health system in the sense that it has a board, a CEO, an executive team, and then each individual entity has, so a hospital has a president, an executive team, a board. and then each department, a department of medicine, a department of, it has that whole org structure, right? And one of the problems with that sort of thing, and in general in healthcare, is the siloization. So there's the nursing world, there's the doctor world, there's the IS and IT world, there's the environmental services, and they rarely talk. And so we are hoping to sort of make our health system more like a real system. So systemness is a word that our CEO often uses. Systemness, not corporateness. And so these are sort of some of the models to think about. When we were planning for our Codathon, we used our social platform for communicating. That 4-member team that won Codapalooza, one works in White Marsh, one at Georgetown, one at Union Memorial, and then there was myself who sort of moves around. So we were able to communicate this way before and after the talk, or the competition. Within our social platform, we have different groups where you could form them organically. Instead of some administrator saying, here's the group for the such and such committee. Well, no, you can say, hey, we're interested in personal wellness and we want to help each other stop eating donuts or something. So we'll have, there's a group here where people are talking about that particular thing. Up here is a private group where nurse practitioners and physicians that work just in open heart surgery communicate. And so when we rolled out a new electronic record, they're saying, oh, well, when we fill out this order form, this bug happens or whatever. So they're able to catalog everything, have conversations about it, and then report all that stuff back to the people that need to know who are rolling out the electronic record. We also use it, at the top you see that app, one of the wayfinding apps. We have people in there, so there were a couple inventors that submitted the idea, but then there are people from other parts of the health system that weigh in and say, why don't you move the button over there? What about this design principle? What about that? And so everybody can weigh in on inventions or apps as they're being created. In one case, we actually completely eliminated a committee for heart surgeons where they used to have to go over devices and then report back at a committee because it's hard to get heart surgeons together. Well, they can complain all they want and hear about the devices, and then somebody else can look at it and make decisions. So anyway, we're finding this to be a pretty powerful tool. We also use it for thinking differently, and that's actually the mantra of MI2, think differently. So while some innovation centers are about tech transfer and some are about process improvement, we really want, we're really focused on thinking differently. And so we have many groups that just focus on those sort of things. So here's one on good design, where when we find everyday examples, we put them. If we find bad examples, like here, we might actually improve our hospital because this plate operates that door, this plate operates a door behind you. This is a sign for throwing out trash. I don't know about you, but I don't want to think when I have to throw out my trash. So we're basically saying, like, poorly designed things, let's improve them. The other thing about social is that we think there may be room to think about it differently, in the sense that, what if a patient's room was a group and the devices were users, okay? And they all communicated in that group, and then the nurse or the clinician could look at it, be in that group also. So it could still be a private section, but the devices are also members of the social community in that sense. So we're exploring some of those things. Now, as far as opportunities to potentially either work together or learn from each other, exchange things. One is that the human factors and usability division may be very applicable to some of the stuff you're doing. They do consulting, but they also do research, lots of research. So it may be that if you're a startup and you want to tie something into a research project that also has a human factors component, you might be able to get something really great out of that. A couple opportunities is that we actually have 2 job openings at MI2. One is for an IT tech transfer, sort of a commercialization officer, and another is for somebody to work with me in the area of presence. So apps, games, influence, and social. I want somebody to I'm looking for somebody to who has admin strengths, but is willing to not be in that job for very long and be sort of an apprentice, because I'm not going to be doing apps in 2 years. I'm going to be, moving on to something else in innovation, right? So I'm planning for my exit strategy. So 2 job opportunities, and then there also, as you know, MedStar is a big clinical laboratory. So if you have research projects of your own that you're already getting started that are related to your products, you know, if you want to test it at Hopkins or Mayo or Cleveland, you're getting this huge health system that has, they don't necessarily represent the rest of healthcare. They are certainly leaders in certain respects, but at MedStar you get the rural, you get the urban, you get the community, you get the university, you get all of these different things, and in two different financial jurisdictions, DC and Maryland, very, very, very different when it comes to funding and how information moves. So, you know, so there's lots of opportunities, I think, for collaboration there. So, any questions? Yeah.
If you had the MedStar logo, I would have never guessed that you work at a hospital, honestly. But we have time for
because I don't have a tie? I don't wear a tie because
no, because of the content.
Oh, okay.
Right? Finding Nemo.
Finding Nemo? Yeah.
If you have research that's funded by another university, can you still collaborate in some way?
Yeah, so sometimes that, what I didn't mention is that we also work closely. MedStar Health has a MedStar Health Research Institute. So we have innovation and research. So I know there's a ton of collaborations between people at the research side. And then there are also some where if somebody brings an invention or idea, we work on, we actually have some ties to the undergrad at University of Maryland with their biotechnology. So we have collaborated on some things there.
So, and do you use folks who do research in social psychology in the influencing aspect?
So that's actually fairly new. We started doing this in October. I was actually when I first presented the idea, I was sort of laughed out of the room as far as influence. And I almost squashed the idea, but one of the people in MI2 said, "Wait a minute,
No,
when everybody laughs, that may be the most
that's
creative
real.
thing you've heard in a long time."
So should a person be in touch with you
For
if
influence.
they're doing research and working in that field?
Yes, if it's influence, it should be me. But if it's influence on the side of, say, usability, there are lots of social psychologists in human factors as well, because they either come through an engineering route or a psychology route. So
Okay,
we
so
have some resources there.
Engineering goes with the human factors, psychology goes with you.
Psychology, well, there's also psychology
Sure.
and human factors. But I'd be a great contact. Anyway,
Okay,
I'll make sure you
all right.
get to the right person.
And then the other thing is, Brad Chambers is my colleague.
Oh yeah, yeah, I know him very, very well.
And this is very interesting to me because I work a lot with Union Memorial, my organization does. I had no idea.
Yeah.
So,
Yeah.
so
I can answer why.
yes, thank you.
Part of it is that we have been operating under the radar for a little while, and we're just sort of up periscoping now.
Okay.
We're sort of maturing underneath the hood, and now we're coming up. So that's why I got it.
Great.
Quick question.
Yeah, quickly, I know that, readmissions are going to be the driving factor for a lot of things, and I was something about it last night, but there are cable companies now that have the ability to interact in the homes with folks, and some of them have their own home care kind of divisions. Have you seen any of that where there's going to be following the patient at home using cable as an interactive to keep patients healthier at home or as a tool?
Using cable, meaning like the
Like
cable
Time
networks.
Warner,
I don't
like
actually.
Time Warner has a group. I don't know if anyone's seen that or heard that. Time Warner's got a home care group.
So I don't mean to usurp, but I worked with a group out in Colorado called Cable Labs.
Okay.
It's a nonprofit organization that kind of is a laboratory for all the major cable companies to come together and come up with innovative ideas and innovative ways to solve problems, and that is something that they're actively looking at.
Which can now be channeled into a hospital on discharge
Yeah.
with home care and kind of follow them.
We do have people who focus on telehealth and mHealth who work with folks like Verizon and these sort of things. Actually, someone in the audience, Pete Solano, works with me, and also in the mHealth world. I don't know, are you aware of us collaborating on anything specifically with cable networks?
It's really, the problem with cable is the power's out, or the cable's out, the data doesn't move. So the better model for what you're alluding to, which is RPM, remote patient monitoring, is moving the data via telephony networks, HT, Verizon, to a lesser degree Sprint and T-Mobile. So the vendor we like right now, above all, there are many,